Listen to your patients. Half the melanomas, probably more than half the melanomas, are found by the patients. They might not know it's a melanoma, but they're worried about it. So if they walk in and they're worried about something, get that information out of them as soon as possible. They will be wrong more than they're right, but still, if they're worried about it, if they've got a story about a changing mole, change trumps everything. If they've got a changing spot, you've got to test that spot. They'll be put at ease by the fact that you tested it and it wasn't a melanoma. Don't feel bad about the fact that you're going to test a lot of things in your career that weren't melanomas. That doesn't make you a bad doctor for giving people unnecessary scars, because they weren't unnecessary scars. The spot you were looking at had a known 1/4 risk of being a melanoma, so it had to go. Other ways of not missing melanomas: look at your melanoma patients with a very suspicious eye. Once a patient's had a melanoma, they've got roughly a 5 times increase compared to baseline risk of getting a second melanoma, unrelated to the first one. So all those patients have a very low threshold for biopsying funny-looking moles or funny-looking pigmented skin lesions. In fact, after those patients grow their first melanoma, you probably owe it to them to get them back perhaps 3 months later and reassess all of their spots with a more malignant point of view, because you can't give their moles the benefit of the doubt anymore, because these patients have had a melanoma. And in fact, people who grow melanomas. They're really good at it. So have that recorded somewhere in the patient's file.